Hello, everyone. Welcome to this webinar. It's a combined webinar of the Journal of Hand Surgery European Volume and the Asia Pacific Wrist Association. Good morning to those in the Americas, good afternoon to those in Europe, and good evening to those in Asia and the Pacific region. So, I'm Matthew Brown. I'm a hand surgeon in Edinburgh here in the UK, and I'll be handing over to my co-host Rebecca Lim in Singapore shortly. Bit of background. So the Journal of Hand Surgeon European volume is a high-impact hand journal, as I'm sure you're aware, and it's the official journal of the Federation of the European Societies for Surgery of the Hand, FESH. Today's topic will talk regarding treatment options, surgical treatment options for degenerative wrist arthritis, particularly more advanced stages of SLAC and SNAC. We are lucky to be joined by the authors of 3 chosen papers, 2 of which will be from the European Journal, 1 of which will be from the Journal of Wrist Surgery. We also have a number of invited experts. We have PC Ho from Hong Kong. We have Bo Liu from Beijing in China, and we have the editors-in-chief of the 2 journals. We have Wei Lam, who is the editor-in-chief of the European Journal. He is working in Singapore and has an honorary role here in Edinburgh. He is the BSSH Hand Society president for the UK next year. We may also be joined by Toshi Nakamura, who is the editor-in-chief of the Journal of Wrist Surgery. I am pleased to be joined by Rebecca Lim, and I'll hand over to Rebecca.
Okay, hi, good morning, afternoon, evening to our friends all over the world. My name is Rebecca. I'm a hand surgeon from Singapore. So this is a combined journal session with JHSE as well as APWA. So APWA stands for the Asia Pacific Wrist Association. It was actually established in April 2015 with experts with a keen interest in the diagnosis and treatment of wrist conditions with a particular interest in arthroscopy. Ever since, the association has grown from strength to strength, and now it has grown exponentially in terms of members and also have their own traveling fellows. So I would like to first introduce the experts. So we have Mr. Dan Brown from Liverpool, UK. He's an honorary associate professor in orthopedics from the University of Liverpool. He's been a consultant since 2003 with multiple publications, research interests, particularly in wrist arthroplasty, outcomes and explant analysis of remotion and Motec implants. And then next we have Professor Bo Liu from Beijing, China. He's a professor of orthopedics from the Zishuitan Hospital. He also has multiple publications with interests in wrist and robotic assisted surgery. And he's also the APWA chair of the Education Committee. And last but not least, we have Dr. PC Ho from Hong Kong, the founding president of APWA. He's the Chief of Service of Orthopedics of the Prince of Wales Hospital with a very keen interest in wrist arthroscopy. And he's also an honorary clinical professor of the Chinese University of Hong Kong. Okay, so without further ado, I'll hand the stage back to Matt, who will kickstart the discussion for paper 1.
Thanks, Rebecca. I'll just introduce our authors. So our first author will be Steven Moran for paper 1, looking at 2 treatment options, four-corner fusion and proximal rocarpectomy. Paper 2 will be delivered by author Richard T, and that will look at whether we excise or keep the triquetrum when we perform a midcarpal fusion. And then our third paper will look at the experiences and research of total wrist arthroplasty with Ole Reigstad from Oslo in Norway. So let's start with paper 1. Our first paper is entitled Proximal rocarpectomy or scaphoid excision and four-corner fusion for the treatment of scapholunate advanced collapse arthritis. Steven Moran is a professor of plastic and orthopedic surgery at the Mayo Clinic in Rochester, Minnesota. He is the immediate past president of the American Society for Surgery of the Hand and currently runs the ASH Young Leaders Program. Steve, take it away.
Thank you, Rebecca. Thank you, Matt. I really appreciate this opportunity. Our paper is a review paper, so I will refer most of the participants today to the paper themselves if they want to see specific articles. I also would like to thank my co-author, Jimmy Lin, for doing a fantastic job. So today's article is really focusing on stage 2 SLAC. When we have evidence of midcarpal arthritis, I don't think anyone would argue with the fact that probably PRC is not appropriate and you need to go to a midcarpal fusion, though we can discuss that later on. So these are really the two options I'll discuss today. I'll briefly touch on neurectomy and some other procedures. I think the biggest thing you could draw from the article is that you need to set appropriate expectations with your patients. The requirements for wrist motion are important for everyone to know, and I think explaining that to the patient will make a big difference. Both of these procedures, four-corner fusion and proximal row carpectomy, are not going to restore normal wrist kinematics, so you will never maintain or obtain better motion than you have than when you start the procedure. We have found in many biomechanical studies that probably the requirements for flexion and extension are about 40 degrees each. You need some ulnar deviation and a very small amount of radial deviation. So starting with four-corner fusion, I don't think there's really a big difference between what you use for fixation. I do think that this is an incredibly difficult operation. It's very technical. You have to remove all the cartilage. You have to be careful not to devascularize the bones. And I think you also have to be careful about putting the soft tissue back together. We do know from historic papers that the failure rate of this procedure can be as high as 63%. I think that's when people were relying upon the circular plate to do all the work for them. And we now know that it's really bony carpentry that makes all the difference. I think most of the more recent papers have shown the failure rate still can be as high as 15%. Why is it such a problem? Well, we now know that the vascularity to the lunate it can be very minimal in some patients. About 10% of patients will only have a volar or a dorsal blood supply. And if you do this procedure open, there's a chance that you may cause a vascular necrosis of the lunate or certainly devascularize the lunate to the point that getting healing through that capitate-lunate interface is very difficult. This is just one example that we see here at our clinic. This is a patient that was sent to us following a perilunate dislocation. They underwent a four-corner fusion, and you can see that in that picture on the right, the entire lunate is dissolved. And now we have a very difficult situation for this patient. So four-corner fusion is a technically demanding operation, and it has several other disadvantages. Long immobilization times, the risk for non-union, increased OR times, I think, over proximal row carpectomy. You can lose the lunate reduction during your fixation, which can result in the patient losing forward flexion or extension after the case. There are many secondary surgeries, and there's increased cost. If we look at the papers that we talk about in the article, probably the best fixation method is now with compression screws in terms of cost utility. And this is certainly a technique that I like to use. I like to go retrograde with my single screw through the capitate and the lunate. We can discuss this later, but this is very amenable to arthroscopic practice, and both Bo and PC can discuss that. Well, then why doesn't everyone do PRC? And the answer is we are always concerned about the development of radiocapitate arthrosis. And this has been discussed in many papers by Peter Jepson and Peter Stern, both of which are probably the most famous. But after 10 years, almost all patients will show evidence of some type of radiocapitate arthritis. And why is that? Because the shape of the capitate is not the same as the lunate fossa. The lunate fossa in most patients is somewhat square, and the capitate is usually much larger than this, resulting in edge wear or shearing forces across the cartilage. You also have to remember that certain capitates are different shapes, and this was shown to us by Steve Villegas. And if you're looking at that capitate down at the bottom right that's very pointed, you would expect that this would go on to develop capitoradial arthritis much quicker. We talk about several articles that we've reviewed, but I'm just going to go over some of the ones that we know really well because we performed them here. One of which was this study that had patients followed up for an average of 20 years. And what we found is that the motion that they had preoperatively was exactly the same as when they came back in for their final follow-up, and very little improvement in the grip strength. We always say that PRC preserves more motion than four-corner fusion. And, I don't know if that's really true. It looks like they're about the same. There was a failure rate of about 15% in this paper. And in our study, most of the failures occurred early. That is in distinction to several other papers in literature that say that most failures occur after a decade. We were able to look at several things that are combined with PRC, like capsular interposition and radial styloidectomy. The only thing that made a difference in this paper and the subsequent paper by Eric Wagner was neurectomy. And so adding an AIN-PIN neurectomy, it's easy for all of us to do, but it is associated with better DASH scores when you follow these patients out. Other things, as we know, age greater than 40, it's been shown in many papers, non-manual labors, and also diagnoses outside of SLAC, which we're not really covering today. So which is better? Well, we always say that better motion with PRC, better grip strength with four-corner fusion. We did a comparative study of patients under the age of 45 years. We had actually very comparable groups, and what we found is really not much of a difference. The one difference we did find, four-corner fusion had lower DASH scores, thus better patient function, but it was only by 10 points. And though statistically significant, is this clinically significant? I don't know. When we looked at failure rates, overall motion, return to the operating room, the other thing that stood out is that four-corner fusion has a higher rate of returning to the operating room, and it's usually for hardware problems. If we look at cost analysis, there's no question the four-corner fusion is more expensive than proximal row carpectomy, and I think that's probably one of the only things we can hang our hat on. In this very interesting study published in the journal Wrist Surgery, they found that the cost of the implants alone was 130% greater than the total cost of taking the patient to the operating room for proximal row carpectomy. So unfortunately, while the article goes through many papers, it's hard to show a big difference between the two procedures. Thanks for your attention.
Thanks, Steve. Great summary. Can I first ask you, Steve, so your reading and your co-authors' reading and your own research, has that at the current time or in recent years influenced your preference? Do you, ignoring perhaps patient factors such as age and whether they're manual or not, do you have a gut feeling or a preference for one of those two operations?
Yes, Matthew, that's a great question. In the US, I think we are biased toward four-corner fusion. In my training, Jim Dobbins, Bill Cooney, Bob Beckenbaugh, all very much slanted toward four-corner fusion, and that really is a bias I have to confront with myself every time I discuss these options with the patients. But we really discuss all the options, what the expected outcome will be, the complication rate, and many times I do this through a process of the shared decision-making with the patient. I do still feel strongly that if it's a heavy manual labor, four-corner fusion will give me a better outcome. And I'm always reminded of patients who'd have to really hammer things in. And I do think that that accelerates the time till we see radiographic changes on proximal row carpectomy as opposed to four-corner fusion.
Mm. When, Steve, would you perform a proximal row carpectomy, or do you avoid?
No, I definitely do it. And, I think Kienbach's disease is one case, certainly. But if we're focusing on SLAC, most patients that are not if they're in a desk job, proximal row carpectomy, definitely the way to go. If they're older patients, which don't have a lot of lifting requirements, proximal row carpectomy, and pretty much any comorbid risk factor that is going to increase their chance of non-union. So smokers usually will get a proximal row carpectomy.
Yeah, great. Thank you, Steve. I'm going to come to Bo, please. So Bo, you're based in Beijing in China, big catchment. Steve's talked about maybe the pattern and preference for four-corner arthrodesis in North America, in the States. Can you comment on your region, China, for example, your own preference and why?
Yeah, so I think we actually generally we don't have different, not different from the Mayo Clinic. Actually, in China, also in my center, we do more and more four-corner fusion nowadays, and less PRC, because we find that nowadays the patient, even the patient with the older patient, now the older patient also has more demanding activities nowadays. We do see quite a lot patient actually has a degenerative changes after PRC within 10 years post-op. So we are more careful about the PRC. We really reserve the PRC for older and older. So and for four-corner fusion, most of our patients in Asia region, we find this they're doing well. And particularly, we all have a concern about the cost. But after if we do use with the KY, most of the time we use screws. The cost now is less when compared to different kind of plate and screws. And also if we choose nowadays, we do more and more arthroscopy approach. So we find less and less complication, and also the range of motion is the patient is generally happy about the four corner fusion. So now we do more and more four corner fusion, even for the patient with older ages.
Yeah, well, definitely come on to arthroscopy. It's fascinating. You know, Steve's review paper did concentrate on some superior outcomes. Bo, also, when you are, obviously you would not perform a four corner fusion if there was a radio lunate arthrosis. But equally, there is discussion with regards to the mid-carpal involvement, so the division between stage 2 and stage 3 SNAC. How do you make an assessment in terms of whether the mid-carpal joint is good or not? Or do you consent patients for both procedures and you look arthroscopy, MRI, X-ray? What is your practice?
Yeah, this is very, very good and also important question. So before operation, we always look for the X-ray CT scan, sometimes MRI, but MRI is not mandatory. But we also we talk to the patient. We will assess the patient under the direct vision of the wrist arthroscopy to make the final decision. Before operation, we talk to the patient about this. And I think one of the advantages of wrist arthroscopy is may allow you to have the direct vision of the cartilage, which is most accurate modality nowadays. So I think it's one of the hand surgeon worldwide should try to take the advantage of this wrist arthroscopy. And most of the time the finding of wrist arthroscopy is not much different from the high quality CT scan or MRI, but it's more direct. You mean so the surgeons they can take pictures and show this kind of a cartilage to the patient as well. So I think it's make the patient also very happy about the shell decision. And also for the four corner fusion, one of the issues is the difficulty in put the screws into the ideal position. Actually the challenging of the procedure is one of the concern of this procedure. We do find that if you do it arthroscopically, you most of the time you cannot see, you cannot open everything and make everything open. So it may take times, but nowadays we find the use of robotics assisted surgery actually the help us a lot. So nowadays we in our center we use robot to help us to do the percutaneous fixation for four corner fusion. We find it dramatically decreases surgical time. Although I know the robotic surgery is not available in many of the centers. I think it's one of the solution in the future. Yeah, I do think so. Yeah. Thanks.
So I'll ask you this, and I'll ask Dan. In terms of four corner versus three corner versus two corner, one column, what's your preference?
Yeah. Yes, I think I didn't personally. Or in my center we didn't didn't make the formal comparison study, but in our practice we do most of the time we do four corner fusion. But we not really do fuse all these four bones like we do. Just like the Steve actually has shown a beautiful actually we just fuse the neonate capitate and also the triquetral hamate. So because there's not much motion between the middle column and the ulnar column, so I think that I do the same with Steve nowadays. Yeah. Which makes the procedure less challenging and quicker.
Yeah. And Dan, what's your preference in terms of column number and what's your metalwork preference?
I used to always do four corner fusions with a circular plate, but the complication rates, even when I think technically I did it very well and the X-rays looked really good, I still often would have problems So more recently, I've been definitely doing middle column fusions. I don't take the triquetrum out because I think as long as the triquetrum's still moving, I don't think it causes too much trouble. I obviously take the whole of the scaphoid out, and I either use 2 cannulated headless compression screws. And more recently, I've been using staples, which seem to work very well and are a bit quicker and easier. But I've got no evidence to suggest one's better than the other.
Yeah. And Dan, do you have a personal preference in terms of your favorite operation? And then does that change based on patient factors like age or occupation?
Yeah, that's a tricky one, and I think it goes back to a bit the assessment. It's really easy if somebody's got really bad arthritis in a particular joint to know you need to do something about it, and it's really easy when they've got no arthritis in a particular joint. The problem is when they've got a bit of arthritis in that joint, and whether you're assessing that with an arthroscope or with a CT scan, you still have no idea whether that minor arthritic change is actually going to be symptomatic when that's the joint you leave behind. In my hands, the most predictable of all of these operations is actually wrist replacement. That actually, even in a patient who might not have pancarpal arthritis, does come into play in an older patient who's not going to be putting a massive amount of weight or force through that wrist. Certainly somebody who's peri-retirement and is looking to ride the bike and have a game of golf, then a wrist replacement becomes a very good option for them, albeit an expensive option.
Yeah, absolutely. Thanks, Dan. PC, I'll come to you. So in your experience and the Hong Kong experience, what is there a general trend towards one or the other? And are there particular factors you look out for? For example, also what metalwork would you use or have you used? What do you like?
Thank you very much. I think partial wrist fusion is always my preference, unless there are really contraindication or the patient doesn't really want to have the implant, fixation things. Because I hate the degeneration, which is often almost 100% after the PRC at the radial cavity joint. This is very unpredictable. Yes, you may say that sometimes it is not painful, but you can also be painful that require revision surgery. So to me, the reliability of the PRC is not that really highly reliable. So unless I found it's highly difficult for offering a fusion, partial fusion, for example, I think very, very heavy smoker, or actually a patient is very old and fragile or very low demand, then I think probably we can go to this sort of relatively simpler solution. So otherwise, I think the partial fusion always gives rise to more reliable outcome in terms of strength, in terms of pain control, and the durability of the surgical outcome. And probably actually the range of motion, I would say that after we doing the arthroscopic type of treatment, the outcome seems to be also very predictable. As I think Steve mentioned, the lunate is actually subject to the risk of complication because of the poor blood supply, relatively poor supply. So I think open surgery not only may increase the chance of the complication, also the chance of non-union, and also the soft tissue compromise. We also may compromise the overall outcome because you need to do a lot of soft tissue dissection, and that will actually get rid of some of the motion that you can obtain in the laboratory. So arthroscopic treatment is really something in practice simulate what we can achieve at laboratory because we do really minimal damage to soft tissue. So that may actually maximize the range of motion. So that's why in our experience, the range of motion is usually quite satisfactory. We can consistently achieve around 60 to 70% of the range of motion of patient with this arthroscopic treatment. So it's been my preference for almost 25 years now. But in terms of the type of surgery, in fact, I initially still do the arthroscopic 4-corner fusion, but since 2009, I shift gear to just the 2-column fusion. That means the middle column, the capillary fusion. And in fact, capillary fusion actually simplify the whole logistics because at the end of the day, the real logistic of the logic for the treatment is actually to prevent collapse and make carpal joint, and in particular the capitate over the remaining lunate. So in fact, what we are focused is just the middle column. The addition of the ulnar column is only improve the union rate, as been reflected by previously the high risk of non-union because of maybe the poor technique, maybe the poor implant, etc. And so I think arthroscopically with this preservation plus supply and with the adequate fixation, usually we do two screw. We use screw because our arthroscopic approach, we won't put play anyway. But I think the screw is reliable enough. We actually do a retrograde screw from the capitate to the lunate instead of doing antegrade. I think when it was first proposed by Joe Slade, the late Joe Slade, actually he did a mini open, getting the two screw at the center of the lunate and then drive into the capitate and provide very strong axial fixation. I personally doesn't like this approach because I think the only articulation remaining will be the radiolunate joint. I don't really want to damage the articular surface of the lunate, which is very precious. So therefore, I decide to do retrograde from capitate to lunate, which will make technically a bit more challenging, but usually it's affordable. So I think I like a boss idea using robot because it probably ease out the technically the really most reliable track of the fusion. And so far the capillary fusion heal very usually we can obtain over 90% union rate, and preserving the triquetrum actually I still prefer because that actually theoretically act around 8 to 10 degree of motion, remaining motion, and we seldom has any triquetral hemi impingement problem if we can make attention to avoid excessive shortening of the carbohydrate. So far that is our experience in Hong Kong. Thank you.
Yeah, great. Thanks, PC. I've got a follow-up question on arthroscopy. So we know the results look good, and but there aren't many people doing it, or at least there aren't perhaps in Europe, there aren't in the UK. You're famed, as is Steve and Bo and others, for arthroscopic techniques. Is this a technique that all, wrist surgeons should embrace, or is it for a select few? What's the learning curve? How many will you do before you feel like you're happy doing it? Do you see?
Well, I think it's not actually suppose it's actually very straightforward because the process is quite straightforward. You just remove the whole scapula or part of scapula. In fact, in our hand, we don't think we need to remove the entire scapula. The distal scapula does not articulate with the radius. So basically, you just remove 3/4 or 4/5 of the scapula. That may save some time. And then if you're doing this sort of, the rest of the thing is just to shape the carpentry, to remove the cartilage, and then put two nicely placed guide pin, and then convert it into a screw. And that is actually pretty straightforward.
Yeah.
Actually, Paco Pignel and Eva Bao even make it simplified is because they will propose that you can even make a mini incision approach to remove the scapula. Actually saves much time, which I do not disagree. Although we still quite insist on a pure arthroscopic approach, which take really more time, maybe 30 minutes more than that. But the rest of it actually is quite. So I think if you have been able to join some arthroscopy course, follow the instruction master, some master, and perhaps it's actually, I think it's not so difficult. The difficulty is really, in fact, is how you place the two screws in the right position. Or you do four corner fusion is actually easier because you can actually put a screw more easy than the single column fusion. Yes.
Yeah. Thank you. Final question before I just ask about the kind of the theme of the January Degenerative edition for the journal. For those on the call on the Zoom that do PRC, an open PRC, is anyone adding an adjunct like radial styloidectomy routinely or a capsular interposition routinely? No. Does anyone add a capsular interposition if there's kind of eburnated proximal or head of capitate? Or would you just choose not to do a PRC? Dan, when would you not do a PRC when looking at the capitate?
I'd want the capitate to be looking healthy. I think we've got other options. I don't think we need to try to make a PRC work in somebody it's not going to work in. I think if a PRC is not the right option, then do something else. There are other things that we can do.
Yeah. Do you do radial styloidectomies for PRCs routinely or sometimes or rarely?
I would if the preoperatively it was very pointy and abnormal. If it was a normal looking radial styloid, I wouldn't touch it. But if it was there was an excessive overgrowth, I would take it off at the same time.
Great, thanks. Final point, Bo.
Yeah, so when talking about the open PRC, so I will always check because you open it, you always check after the PRC, you always check any impaction actually on table. You can check any impaction. So most of the time I will find some impaction when you're doing radial derivation particularly. So most of the time I will do the radial steroidectomy, which is a simple procedure. And also addition to PC about the arthroscopy and also equatorial question. I think so nowadays the young generation of hand surgeons should always try to learn how to use arthroscopy to do this kind of minimally procedures. Actually, the advantage we have mentioned, and also actually is not so challenging. The technical is not so challenging as Peter had mentioned, and also I think that we also need to combine the open and the arthroscopy procedure like like Peter also mentioned, we can do a mini incision at the radial side or volar side of the wrist to take out the scaphoid very quickly. And also with the use of wrist arthroscopy, we have an opportunity to do not use bone graft for the focal fusion or partial fusion, because most of the time we can see very clearly how much we take the bone and without sacrifice the height of the carpers. So I think it's one of the also the advantage of this mini-invasive procedure thing.
Yeah, great. Thank you, Bo. So editor-in-chief of the journal, this paper featured in the January journal, which was themed on the degenerative wrist. Tell us a bit about your thoughts on why that theme was brought about and the papers that were chosen.
Thank you, Matt. First of all, let me say what an honor it is to partner with APWA. Delighted to be to have the General Hand Surgery European volume for this joint journal club. Yeah, so the degenerate issue in 2025 is a very significant issue. It is the first issue that has gone online. As you know, the journal went online this year, so it is the first issue. We decided to make it a special issue, and we decided on the theme of the degenerate wrist. Now that's obviously a very big topic, so we did take a long time to decide on the papers that we want to include. We specifically did not want to include CMC joint arthroplasty and CMC joint arthritis because we think that would just take over the whole issue. We decided to have an article on the STT joint that's not covered very well. A lot of papers have been published, especially in the European literature by Ole and Dan, especially on total wrist arthroplasty, and we felt that was very important. We felt that total wrist arthrodesis was kind of forgotten and was important to look at that. So that was how we chose the article. There was also a very good further knowledge article by Sumet and Ian Trail about decision making. So a big section on wrist innovation there as well. So that's how we make the decision, and I hope everybody will read it. Maybe we should have included a bit more arthroscopy, but we thought that there was enough papers to fill up the issue already. Thank you.
Okay, so that was a very scintillating first paper discussion. And now we're going to move on to paper 2. So thank you, Matt, for doing the first part of the journal club. So next up, we have Team Down Under. So may I invite Richard T., the first author of the paper, entitled Mid-Carpal Arthrodesis with or Without Excision of the Triquetrum, a Systematic Review. Could you kindly share your slides, please? So meta-analysis is simply not possible with the variety of fusion options available across the literature. A little bit about Richard. He's a plastic, reconstructive, and hand surgeon who's currently practicing in Sydney, Australia, graduated from the University of Adelaide and did his PhD in tissue engineering at the Bernard O'Brien Institute of Microsurgery and University of Melbourne. So the stage is yours, Richard.
Thanks, Bex. I'm probably one of the more junior surgeon amongst the group, but it's a great pleasure to be able to present our systematic review. So it's interesting to hear a lot of the expert panel talking about three corner versus versus four corner fusion. So our outcome may suggest something a little bit different, but I hope that may be able to generate some discussion. So we did a systematic review at the orthopedic department at Dandenong Hospital at Monash Health in Melbourne. So very simply, the mid-carpal arthrodesis commonly comes in the form of four-corner fusion. Sorry, actually, yep. And together with PRC, it's two of the more common management options for slack or snag wrist in stage 2 or 3. So there are a few different types of mid-carpal arthrodesis, which in our search we attempted to define them more clearly. So we talked about the middle column fusion, lunocapitate fusion, which is also called a two-corner fusion, and it started off without excising the trochlearum. However, there's been some report in the evolution of the procedure by some author in the literature, and this is where it gets a bit interesting that there is some concerns about impingement as well as peritrochlearal arthritis. And therefore, in the evolution of the technique, two-corner fusion eventually adopted the excision of the trochlearum, at least in the published data anyways. And then there's also the three-corner fusion, which always include the excision of the trochlearum. We'll talk a little bit more in the next slide. So the decision between two versus three-corner fusion, in some of the authors, they actually explain a bit more clearly in that the Viegas type lunate actually dictates what they do. And in the type 2 lunate, when you attempt to just do a lunocapitate, which is a two-corner fusion, a lot of the time you have to shift the position of the lunate and the capitate in order to have the maximal contact area between the lunate and the capitate. And there's some concerns that when you attempt to do that, the RSC, the radioscaphocapitate ligament, is going to tighten and it will cause more stiffness. So a lot of the details and nuances between the 2, 3, and versus 4 listed here on the table. I suggest that anyone interested can have a read. And we come to the removal of the trochlearum, which we were interested in. In a lunocapitate fusion with the removal of trochlearum, Professor Greg Bain from Adelaide suggested in his biomechanical study that you actually get a better range of motion, especially in the radial ulnar motion. So in our paper, we wanted to look at or answer this question: that does removal of trochlearum improve the outcomes, such as the range of motion, pain, and grip strength? And we basically compared all the mid-carpal arthrodesis with trochlearum excision versus the mid-carpal arthrodesis without. And so only the cases with more modern compressive osteosynthesis were included. So we excluded all the ones that were fused using K-wires. Meta-analysis was not possible, so we only use pooled data mean for comparison. And so the main findings, just to summarize here, so with trochlearum excision, there's actually a 15-degree of flexion extension motion advantage. And just remember that this is a pool mean data. And with the trochlearum excision for the radial ulnar motion, there is also a 15-degree advantage. So the secondary findings were that the four-corner fusion actually have a 8 kilograms grip advantage over trochlearum excision. And there's no obvious pain score differences between the two groups. So the findings with regards to the complication, there were a history of poorer union rates for the two-corner and the three-corner fusion. But in here, the four-corner fusion union rate was about 93.6%. The three-corner fusion was 89.6%, while the two-corner fusion was 95%. So there's actually not a significant difference between the three techniques. There's also some concerns about the loading of some biomechanical studies suggesting that the loading when you excise the trochristrum may increase the radiolunate narrowing and osteoarthritis. But it appears that the four-corner fusion also has quite a lot of radiolunate changes as well as arthritis compared to the two-corner or three-corner fusion. And this is a list of it. And I just wanted to point out some of the panelists were saying that they don't tend to excise the trochristrum, leaving it there. But I guess at least in the limited literature that was published and we reviewed, they reported quite a bit of arthritic changes around the trochristrum, which then subsequently prompted them to change their technique into removing the trochristrum. So a summary of our systematic review, there's been a poor data collection, lack of controlled trial, and almost all are case series with one quasi-controlled trial. And with the use of our pooled data mean analysis with trochristrum excision, there seems to be a small advantage of increase or improve wrist range of motion compared to the four-corner fusion. In the four-corner fusion, however, there seems to be a good strength advantage. The unit rate is approximately similar between all three. The radiolunate changes appears to be prevalent in the four-corner fusion, despite some authors suggesting that that they're more concerned about it in the lunar capitate fusion. So just a little bit of advertisement in advance that there is a randomized control trial that's being done at the Monash Health. So we completed the data collection, and currently we are in the analysis phase. And thanks a lot.
Okay, thank you, Richard, for sharing your paper with us. I think that there are some questions in the Q&A box, and I think this would probably lay the foundation for the questions that we're going to discuss for paper 2. So, I mean, we're doing all the mid-carpal arthrodesis and all that is mainly because patients are probably debilitating, have some form of debilitating pain. And I think there's a discussion on whether wrist denervation actually makes any significant differences in patient outcome. So, first, I'd just like to ask Richard, do you actually do any partial or total wrist denervation? And if yes, why? If no, why?
Yeah, so I actually try to offer patient a partial wrist denervation, but my technique sometimes is a bit nuanced depending on the symptoms of the patient. And I have to say that my experience isn't that long, my follow-up isn't that long, but so far, at least the patient tells me that, and I was able to delay a few mid-carpal arthrodesis or even like a wrist replacement because of that. So what I do is that I try to determine like whereabouts in the wrist the pain is located. So I think that for the partial wrist fusion, which classically described by Richard Berger, was that you excise the AIN and the PIN through one single incision, which I think it works well for the middle column pain. And if the patient so changes on the radial side, I mean, of course, you can do a radial solidectomy, but I also offered a similar denervation for the CMC joint, but more on the radial side for the patient. But obviously, that would then increase the type of excision, and there will be more superficial scarring. But that's what I do. But my experience is a bit limited. I'll be interested to hear what other expert on the panel thinks.
Okay, thank you, Richard.
Rebecca,
So maybe we'll ask.
Sorry,
Oh, yes, Eugene.
I'll just continue on that. I think the ideal patient for, I think, a wrist denervation to consider is a patient that you may want to consider doing a partial fusion, but they've got excellent range of motion. And that you know that we're going to lose maybe 30 to 40% of range of motion if you're going to do a partial fusion. So I think in those patients that they've got pain, but they want to preserve that motion, I think a trial of a partial wrist denervation is a good temporary measure, at least, to consider then before compromising the range of motion with partial fusion. So I think they're my ideal patients, those that have arthritis that have good range of motion.
Okay. Yes, thank you, Eugene. So perhaps we ask Dr. Ho, do you actually do any partial or total wrist denervation, or do you actually even trial it in the clinic first with a wrist block to see if it works? How is your practice like for this mode of? Dr. Ho, you are muted.
Okay, yes, so thank you. Thank you,
Yes.
Rebecca. Regarding I think is still a useful technique to relieve pain, at least partially. But I usually reserve to those patients, first of all, who don't want to have a major mechanical type of solution, like what we have discussed so far, because of the complexity of the surgery, or the patient has already exhausted some of the previous surgical treatment, but do not want to go to the ultimate treatment, for example, total wrist fusion, and we just want to get some pain relief. So I will offer this. And before that, consider surgery, I always do a block test at my clinic to see whether a block injection will make a difference. Typically, I will inject between the intraosseous membrane about 5 centimeters above the disc radius. I will inject quite a lot of lidocaine. In fact, I usually inject 10 ml. It sounds like a quite big volume, but in fact, because I want to make sure that my injection will actually reach the nerve. And even using a 10 ml, if we inject right over the IOM, usually they will not produce any sensory deficit. I also want to show the patient that this neurectomy actually will not cause any damage to the sensation. Then you gain some trust of the patient, because usually patient will go, oh, you denervate my nerve, what happened to my hand function, etc. So I really want to show them this actually is no harm effect. Then of course I document for example, range of motion, pain during a movement, grip strength, before and after. And usually I leave around at least 15 minutes for me to test. I don't, we assess after 2 minutes, at least too early. I think at least 15 minutes. I ask them to go out of the clinic and then come back and so on, let me test and then do this. So usually I think in this way, perhaps it will predict the outcome better than, because we know that some papers say that there are actually no predictive value, but I think if we do in this dedicated way, it perhaps is more reliable. Otherwise, I always prefer the mechanical solution, frankly speaking, because I think if there's a pain generation because of the degenerative risk, there always you can use mechanical methods solution to remove the pain generator, and then you probably keep stabilizing the remaining unstable segment. And usually, when the stability is maintained and the motion can be maximally preserved, the pain generator will go away. But having said so, I think it's also important to usually in the arthroscopic treatment, there is an advantage. You can also assess the entire risk. Some of the pain is actually due to synovitis. So therefore, you also need to do a good synovectomy work together with the stabilization procedure and the pain removal procedure. Then the outcome will be more reliable. And because I'm doing arthroscopic treatment, unlike open surgery, you act on the neurectomy is just a very easy technique because the same incision, etc. But if I insist on doing arthroscopic surgery, and if I have to do the neurectomy, then I have to do another incision. Frankly speaking, I think I would like to try the mechanical solution, so which is usually most patients will work. And then I reserve neurectomy to the situation that I mentioned earlier on. That's my approach.
Okay, wow, it's really interesting. Thank you, Dr. Ho. What about Mr. Dan? What is your approach to partial and total wrist innervation? Do you do that in your practice?
Yeah, I do, and I think I probably agree with everything that's been said. I think I only do partial neurectomies. I agree it's really for central pain. I don't think it gets rid of radial-sided pain very well at all. I use it in people who've got good movement, who want to avoid major surgery, particularly in young people who you're trying to delay major surgery. Because if you can do a small neurectomy and buy them 5 or 10 years before you then need to do any major salvage surgery to the wrist, I think that's the best use of it, I think.
Okay, thank you. And then what about Mr. Beaulieu? Do you do any partial or total wrist denervation procedures?
Yes, I agree that the degeneration is a viable alternative for this degenerative disease. However, in my region, in my center, we do less and less nowadays because like the center in China, we treat patients with tertiary center. We treat patients all around the country, 1,000 kilometers away. So the patient actually they do need some do want some really reliable, predictable procedure. And at the same time, most of patients nowadays they have a social media group. They have discussed a lot in before they come to see the doctor. That once we opt the wrist arthroscopy procedure, minimally invasive procedure, in the last 10 years, less and less patient actually they want additional incision, like PC have mentioned, additional incision, which is much larger than the wrist arthroscopy procedures. So for the surgeons and for the patients factor, so we do less and less. But I agree this is one of the viable alternative. But in our region, it's not in so prevalence. Yeah.
Okay, thank you, Mr. Liu. So we are joined by Mr. Toshi Nakamura, the Chief Editor of JWS. So hi, Mr. Nakamura. Yes, I just would like to ask you, what do you think, because the paper 2 was selected for this team, in particular for this paper, do you find, what are the key merit points do you think this paper is good for our audience to know about?
I think that mid-carpal fusion was normally that started with a four-corner fusion, but recently that the Greg actually reported that the two-corner fusion is much better. So we would like to know that which was better in the literature. Then that is why that we actually accept this systematic review. Then that can actually mention us very well about two-corner fusion or three-corner fusion is much better for the range of motion, and the four-corner fusion was still advantage for the grip power. So we need to have a much more comparative prospective study on this kind of things. And also that the partial denervation or total denervation is also another issue. Then we need to clarify that maybe that we will try to do in arthroscopic fashion that we don't need to do a partial or a total neurectomy. However, that when we do an open fashion, then we need to cut at least a posterior interosseous nerve. So we're still going on to this kind of things in the journal. Thank you.
Okay, thank you, Mr. Nakamura. So I'd just like to find out from the panelists, just a show of hands, how many of you actually do arthroscopic PRC or arthroscopic four-corner fusions, or are you mainly like do only open procedures? Arthroscopic assisted or pure open procedures? How many are for just only open procedures? Okay, and arthroscopy? Okay, so the open procedures are still more popular among the panelists. I think the arthroscopy, definitely there's a learning curve to it. And I think open procedures are still more common. So maybe we find out from the, yes, Dr. Ho, your hand is up. Would you like to give your comments?
Thank you. I think I do have some question for Richard because
Okay.
I think it's nice to see some summary, like, for example, two-corner or three-corner with excision of the atrium will give better range of motion than the four-corner fusion. But actually, I would like to know, because I do not excise the triquetrum. I value the triquetrum a lot, so I do not want to remove the triquetrum. Do you have data, say, exactly like two-corner fusion without triquetrum excision? Would the range of motion be comparable or better than the four-corner fusion? That is the number one. Number two question is related whether in the later changes, because the big worry, apart from removing the triquetrum, it may actually, although it may actually gain some motion theoretically or in your review, but the worry is about the long-term issue, because when we remove more bone from the wrist joint, the low concentration will be more, and this low concentration, would that be actually constitute a long-term problem, like the joint viability, whether the degenerative changes we said in earlier, because most of these patients are still in the younger working age. So how long this, if you remove the bone, just articulating the lunate, supporting the entire hand, would that be last long? So that is my two questions.
Thanks a lot for that. To answer your first question, does it actually increase the range of motion? So in a more scientific way, we can't really tell. So I've stated and I've sort of reemphasized that the data that we have is the best that we can, which is we pulled all the data together that are comparable, and then we try to average them, and we basically get a mean of what the result is from all these articles. And the outcome is like so for the flexion extension, there's about 30 degrees better, because in four corner fusion, the post-op analysis showed that the four corner fusion actually has decreased range of motion for the flexion extension compared to pre-operation. So post-op is less than pre-op. However, in the mid-carpal fusion with the trochlear excision, you get slightly improved range of motion. And but the advantage is only about 30 degrees. So I'm not sure whether that ultimately would mean something, because the other patient-reported outcome measures, there's no consistent report amongst these studies that we've narrowed down to. So we weren't able to make a conclusion out of that. And so that's the case. And in terms of radial ulnar motion, again, it's a pooled data mean. So we average all the data that is available, and showed that there is an advantage of excising the trochlear. Now, however, in conjunction with the second question, which is whether there's a long-term follow-up in terms of the loading with the trochlear excision. So the answer is that I think there's a bias, because the four corner fusion data actually has longer follow-up. Although we did limit the systematic review to at least have a year of follow-up, but most of the four corner fusion has a skewed towards a longer-term follow-up. And in our article, the complication table, you can see that there's actually reports of more changes. In fact, the question of loading, the four corner fusion outcome, when we try to compile all the complication, actually showed that there are more cases of X-ray changes in the radial lunate joint as opposed to the 2 and 3 corner fusion. But we pointed out that there is a bias there just because of the longer follow-up of the 4 corner fusion. We did try to look at it, but look into it, whether the 2 corner fusion and the 3 corner fusion has the with the trochlear excision has that loading problem, but turned out to be opposite. Now, in terms of the specific about trochlear excision, the authors, when they excise it, they did mention that they tried to just shell out the trochlear while preserving the capsule around it for proprioceptive reason. Whether that made a difference, I can't really tell, but that's what we can see. But overall, it's a poor quality information from the literature so far.
But Richard, do you actually look at those group compared with and without trochlear excision for the two corner, for example, 2 corner fusion? Do you look at the result with or without trochlear excision? Does it make a difference? That means 2 corner with trochlear excision and 2 corner without trochlear excision. Is the results different?
Yeah. Okay. So so that there is actually only one very small group. I think there was only one paper. So firstly, number one, we basically use mid-carpal. We basically use 4 corner fusion as the group without trochlear excision, and the reason being that the only paper that has published outcomes on 2 corner fusion without trochlear excision, the number is just so few. I think there's only 2 papers reported on that. So the outcomes is pretty similar, but again, it's only 2 papers. I think even the number in the series is pretty small as well. And so we didn't end up including that. But there is a sort of sub-analysis. If you're interested, you can have a look at the papers in the supplementary section.
Yeah, thank you for clarifying. I think we need more work to do on this aspect. Thank you.
Yeah, I think based on Richard's analysis, if you compare triquetral excision versus a 2CF without triquetral excision, there's actually no obvious range of motion difference. So I think the jury is still out there whether it's tricuspid excision is absolutely necessary for better ROM. The question is, the answer is not out yet. Yeah.
Yeah,
Okay,
the number is very small, so that's why we
Too
kept
small.
that in supplementary section.
Thanks, Rebecca. Neat little paper, I like it. We're going to move on just in the interest of time, but we can touch on the topics raised in a moment. So I'll introduce Ole Reigstad from Oslo in Norway. So Ole wrote the paper, Total Wrist Arthroplasty, Recent Advances and Current Recommendations, looking at the literature and also his own vast experience using the Motec wrist. He developed the precursor to the Motec wrist, and his PhD originally was in the development and implantation of wrist replacements. So I'll hand over to Ole to present his review.
Thank you. And thank you for the opportunity to present my paper and my experience. I have a disclosure, and but I have to start with talking about what this paper is for me. It's a so-called expert opinion, but as you all know, this is scientific level number 6. It's just one step up from the pub. But anyway, it is my accumulated arthroplasty experience, and it is how we have achieved relatively good and predictable results in the majority of our patients. And we have how we try to reduce the complication rate with this relatively complicated surgery. It's now 135 years since the first arthroplasty was implanted by Themistocles Gluck. He was a very skilled surgeon and innovative. He used ivory, which was not the worst material, but implanted it in the wrong patient, the TBC wrist. And it took 70 years until the next wrist arthroplasties were introduced. All of these arthroplasties from the 60s and 70s have been removed from the market. As of now, all implants are intended for uncemented use, although they are it's possible to use cement for fixation. They should be rough blasted, either titanium alloy implants or at least titanium plasma sprayed, to secure osseointegration, which is the basics for long-term functioning systems. As of now, there are, it's running its own life here. As of now, there are 2 systems available in Europe, the Remotion, which we have operated around 40 patients of, and the Motec, which I have operated a couple of hundred patients with that implant. The Freedom is available in the US, as well as 2 newly introduced implants. They are not available in Europe as of now. The surgeon is the major, well, it's the one thing that you and me can do better. It's important that they use a lot of energy on getting skills for this relatively complicated surgery, and should never be first surgery or first wrist surgery. It's important to learn from others' mistakes, and I think that Danny has a very good paper on the learning curve, which everybody should read before they embark on this journey. If you fail, do analyze the cases, try to identify the cause, and if you find it, try again. The patient is if you're getting skilled, it's still where the shit hits the fan. Start with a winner like this beauty here, good indication, good bone stock, and good mentality, and try to choose these patients further down the road. It's not, at least not in my experience, it's not the problem with whether or not the patients are high demand or they use their wrist. It's if it's the way they understand what they will get and what they will not get from the surgery. Stay away from the non-compliant patients and stay away from the extremely passive ones. If they're not able to do the necessary training after surgery, they will have a lousy result. Of course, personality disorder patients are always difficult. I try not to operate them, and it's easier if you do an arthrodesis in these patients. And then finally, what can the patients expect? It's not, they must understand that this is not miracle surgery and that we're competing with the stiff wrist, not the wrist of a 17-year-old boy. They get significant pain reduction. They get a good range of motion. The majority of patients have a range of motion around the functional range, 120 to 130 degrees, and they get increased grip strength after surgery. Finally, the surgeon needs to have a strategy to manage complications and revision because there are problems with this surgery. The common there are the usual complications and the implant-specific ones. I prefer to have the Motec as a revision arthroplasty because it has a lot of different sizes and it's possible to adjust it to the patient's anatomy. Revision surgery is even more complicated, and you should ally up with a friend or with a referral center and discuss before you embark on revision cases. So finally, it's, for me at least, it offers quite good results, both in terms of pain reduction and range of motion. In Europe, we're not going to get any new devices because it's because of regulations. So we have to be better at doing surgery and selecting patients. If you do this, collaborate with the other colleagues. I like it, and I prefer to have these meetings with the colleagues to help me to see problems and get better patient results. Thank you.
Thanks, Ole. A great summary. Great to hear your experience. Very pleased I'm the ideal candidate for a wrist replacement. A question. So, I look back at your 2017 paper looking at the Motec outcomes, and it showed quite an impressive increased range of motion. Active range, pre-op 97, post-op 126 degrees. When you are discussing wrist replacement with your patients, obviously you're not promising increased movement perhaps, but how are you describing how it will affect their wrist movements? Because that's obviously the point of this.
Well, I tell them I hope they get what we call the functional range, the dorsal flexion and some volar for taking care of perianal yourself. And then what people really like is radial and ulnar deviation, because everybody works on a computer or a board, and that's actually where I think that the most important part of wrist arthroplasty surgery as compared to arthrodesis is. But I do not promise them anything. The guys, the patients who have very good range of motion, I tell them they'll get a bit stiffer. If they have very little range of motion, I tell them they will get better, because and that's also the experience. We have a series of 12 patients where we did re-articulation from arthrodesis, and they achieved around 100 degrees range of motion, so a bit less than primer, but it's they are very satisfied.
That's great. Can I just have a quick show of hands? Everyone on the call, on the Zoom, can you raise your hand if you perform wrist arthroplasty at all? Total wrist. Yeah, so a reasonable number. Dan, I'll come to you. Which implant do you use, or plural use, And what are your indications for either or? And talk about the rheumatoid wrist as well. What should we consider?
So I started as a consultant in about 2003, and in about 2005 did my first remotion wrist replacement for rheumatoid. I inherited quite a large rheumatoid practice from a conservative surgeon who may well have already had an arthrodesed wrist on the other side, and were very concerned that they wouldn't be able to do their activities of daily living with two arthrodesed wrists. I find the remotion for rheumatoids is a good prosthesis, and it gives you a functional range of movement if you stick to the functional range of movement quoted movements, which are at the lesser end of the scale. They get an arc of about 40 to 50 degrees of movement, not a lot of radial ulnar deviation, but enough to be beneficial over a fusion. As the anti-TNF drugs took over, I was seeing less and less rheumatoid patients, and I wasn't convinced the remotion was a good prosthesis for younger osteoarthritic patients, which is when I started using the Motec. And I use the Motec for the vast majority of patients these days, and they get significantly better range of movement than my remotion patients. And there lies the problem. If you have a deformity to your wrist before you start operating on the patients, because you get more movement, that deformity actually can get worse unless you do something to rebalance the wrist. So I still think the remotion has a place for rheumatoid patients, particularly those who've got ulnar deviation at their MCP joints or radial deviation at their radiocarpal joint, because you will give them some flexion and extension without making their radial deviation deformity worse.
Mm. And Dan, tell me, in your experience, what would be one of the top reasons for patients not being satisfied with a wrist replacement? And secondarily, what are your thoughts or tips or tricks on trying to provide the best outcome, let's say from the Motec?
The most unhappy patients after a Motec are the rheumatoid patients I've ended up in radial deviation, which we've just discussed. So I think anybody who gets a fixed malposition after having a replacement is unhappy, because obviously they had the replacement to try to give them some functional movement back. So I think before you start, you need to make sure that there isn't any significant deformity in the wrist, and that the patients have got some movement or ability to move around neutral. So if they turn up in fixed flexion deformity, that's probably not a good case. You want somebody who, even if they've not got much movement, if they start from neutral and they can show you they can get a little bit of extension, then you're likely to give them functional movement back. I think, like most joint replacements, don't overstuff them. There's obviously a worry that you're going to make it unstable and it'll dislocate. Well, you won't. There've been about 7,000 Motec wrist replacements performed, and to our knowledge, there've only ever been 4 dislocations, all 4 of which were traumatic, so a patient falling on it. In all 4 of them, they had a manipulation under anesthesia and put it back into joint, and in all 4 of them, they then continued to work perfectly well. So instability isn't a problem. So you basically want to make sure on table that you've got really, really excellent movement in terms of radial ulnar deviation and potentially completely free circumduction. And if you've got that, then the patients are likely to get a good outcome. I warn them that there's a 10% chance that they'll need a further operation in the first year or 2 for a technical issue. Now we've got rid of impingement issues by banning the short neck prosthesis. The biggest 2 complications are failure of osseointegration of the metacarpal component. And if you try to put too big an implant to stop that happening, you increase the risk of periprosthetic metacarpal fracture.
And another question for you, Dan. There's 2 types of patients. So who would be your golden or headline patient you're pleased to be doing the replacement on? And then in terms of patient factors, maybe age, maybe employment. And then who's a more absolute contraindication beyond the obvious, like an infection?
I'd like the patient to be vaguely sensible and have vaguely realistic expectations. And as long as they're vaguely sensible and have realistic expectations, then you can put a Motec in anybody. You need them to understand it's a mechanical device, and like any mechanical device, it's going to have a life expectancy and it will wear out. And if they go completely and utterly crazy and carry on lifting, 200 kilo with a bar at the wrist in extension, then don't be very surprised if they get eccentric wear as a result of it. If they are working as a HDV driver and they themselves have got to lift everything into the back of the wagon, it'll wear out. If they can modify their job so they're not doing that massively heavy stuff, then that's fine. If they're a sports person, if they want to play golf or tennis or swim or cycle, that's fine. If they want to go back to competitive boxing, that's probably not a good idea. So they just need to accept the fact that you are giving them a mechanical device and they need to look after it. And as long as they do that, then that's absolutely fine. In terms of relatively contraindications, it's going to be the people who you can't have that conversation with, who are totally refused to modify their activities. I mean, Ole, as he talked a minute ago about the fact you can turn a fusion into a replacement. You can very easily turn a replacement into a fusion. So we often have a conversation with the patient, okay, you are 40. If I do your wrist replacement now, it's likely to wear out in your 50s. You can probably have a revision wrist replacement in your 50s, which will wear out in your 60s. And in your 60s, then you need to accept the fact that you ultimately are going to end up with a fused wrist. And if you want your window of movement now, then you can have a wrist replacement. But you have to accept the fact it's not going to last forever.
Yeah, thanks, Dan. Ole, coming back to you, I know your paper does outline your thoughts on ideal patients and characteristics, but, following on from Dan, what do you agree with and what are your thoughts?
No, I agree with Dan. To take the worst patients, they are the ones where inside of my head, I see that this is not a good idea, but I feel sorry for the patient, and I think they should get an opportunity to have an arthroplasty and motion in their wrist. So I tell them the same as Danny. This is a postponement of a wrist arthrodesis, but activity that has been the major concern since we started with arthroplasties in 2005. But they fare the best. The active ones, the carpenters, the guys, they want to use it when they're out of their cast and they start to rehabilitate. They use it and they get excellent range of motion. And maybe they wear out in 10, 15, 20 years, but those patients have been easy to revise. But the patients where the expectations, where I haven't understood the patient's expectations, or they think that this is an active device that will give them range of motion, that's when I get problems. The fixed malpositions I never do anymore, but we tried to do tendon transfer in the same operation, and at least in Norway it hasn't worked in any of them. I've used rheumatoids who are fixed in fixed malpositions, but now I do much more rheumatoid patients, and I like it very much also with the wrist arthroplasty. Because they are the best patients with pain and everything. They're never complaining, and they are really eager to try to get function. So I like them very much, and I don't use the remotion. I use the multi.
Yeah, great. Thanks, Ole. Steve, I'm going to come to you. So in your practice, or the wider North American or US practice, where does wrist arthroplasty sit? And also, who do you think or what centers should be doing this? Every hospital, or where do you stand on that?
Well, I think in the US, we primarily rely on, in and Ollie, you probably could speak to this better than me, the toroid construction of the joint. I think the spherical construction of the Motec, as you guys have shown, produces excellent results, and I don't think we have been able to achieve those here. So I think that the centers that should be doing it probably see a high number of patients, but also are willing to operate on the complications. I think that's probably the biggest discriminator that we have. I mean, if you're going to do the surgery, you have to know how to handle the complications, and they're going to happen. But I do agree, as Dan and Ollie have said, it's an amazing operation. The patients are so happy, and I have had the opportunity, Ollie, as you said, to take down several fusions and put in joint replacements. And for patients with slack arthritis, I think it's just an amazing option. The patients are always so much happier, in my mind, than after a four-corner fusion or proximal carpectomy.
Thank you, Steve. Bo, in China, what prostheses may be available, and are there patient specific? I'm sure I'm aware of those.
Yeah, so actually to date, I believe most of the surgeons here will agree that we do not have perfect implant for our patient to date. So actually we still do not know what the patient really want. I think the patient really want is not just the range of motion, flexion, extension, radial, or deviation. Actually, we are doing a study on we try to find out what the daily activity nowadays, modern daily activity of the patients require in that age of group. So we use the computer model to actually to mimic all the activity the patient need with a group of patients, and then we calculate what we call the functional range of motion, not just flexion, extension, or radial deviation. It's two-dimensional. So we try to find all the directions which directions are really need for our patients. So with the calculation of with the system of now we are trying to use the computer and AI to help us to find out what's the ideal model for this group of patients or for the certain group of patients, particularly in China or in Asia. So the current commercial available prosthesis is not so ideal for our group of patients. The size, the anatomical parameters is not ideal for this group of patients. So now we are using the 3D printing technique to do this bespoke prosthesis, hopefully will better fit our group of patients, but we are just on the beginning. So we start this study. The longest follow-up of 3D printing patient-specific prosthesis is the longest is only 3 to 4 years. So it's not long, but we are not in my center. We are doing seriously doing the registry for this kind of 3D printing bespoke prosthesis. We hope to find out and also future is find out some patient specific, because a bit different patient have different demands, so not universally fit for the commercial available prosthesis. So different occupation, different like musician, like some heavy labor, different group of patient. I think it's one of the potential direction for the hand surgeons to think about. Yeah.
Thanks, Bo. Dr. Ho, I'm just going to come and ask your experience, and also ask, how should we follow these patients up? Should we be seeing them annually? Should we be repeating radiographs? We know that some wear, closer to the 7 to 10 year mark. What are your thoughts?
Thank you. So, first of all, my experience is limited to just 2 implants, the BiX and also the remotion. I started to do total wrist replacement in 2004 with the BiX. In fact, I was very happy with the BiX, but in 2 years' time, it's already obsolete in the market because of some unknown reason at that time. So I changed to the remotion implant actually as late as about 2011 or so. Actually, there's a window period in between. Is the key issue because we don't have implant in Hong Kong. The company not interested such a very little small market. They really doesn't want to really distribute. I think there's the same issue in Asia as a whole, because the utilization rate is so low that actually the company doesn't. So I did a lot of negotiation with the company in order to let them to distribute the implant again. So finally, in 2014, they redistribute. It's mainly the Stryker. Actually, it's the small SBI initially, and which is actually sells the remotion. And later on, of course, now we know it's by Stryker. We are in a short period of time, we have a universal, but actually, again, it's no longer available. So basically, in Hong Kong, we only has the remotion at the moment. And this is the implant that I continue to use for the past 10 years. So frankly speaking, I think overall, I totally agree with all the speakers. I'm very happy with the result of the total wrist replacement, despite certainly I don't have what only the requirement about the case volume. I cannot meet your standard, sorry, but I'm still happy with the result, because I think technically, although it's challenging, but if you are sufficiently experienced hand surgeon, and you will follow the the instruction, the manual, etc., actually it's not too difficult. So you can actually not too difficult to produce a reproducible result. And frankly speaking, all my patients actually are happy. And I totally agree that the rheumatoid patients are particularly good, because they actually often has a very multiple problem. And if you can solve one problem decently, they thank you very much. And in fact, because the work demand, they also have very little chance of causing a deterioration. So I continue to happy to serve the rheumatoid patient. I even perform the patient with deformity, with a fixed deformity and also volar subluxation. I try to continue to drop, and I found that if you do sufficient soft tissue rebalancing, dissection, including the volar tissue, and rebalancing by some sort of reattachment extensor, because most of the patient has attenuation of the extensor tendon, and because of the chronic deformity. So you need to refix the tendon. And if the tendon is not strong enough, you do some tendon transfer in order to augment. The important thing, you have to get a healthy motor for them to get the extension again and get the radial deviation function again. So this is actually, if you follow this principle, I think the result will be quite predictable. Having said so, I'm a little bit disappointed by the remotion, because when you follow up radiologically, they often has radiological inferiority. For example, distal subsidence of the implant, a bit loosening halo around the screw, particular distal component, is often always 100% happens in all my case. But interestingly, almost all my cases no symptom. I only have to revise just one case of because very extensive osteolysis. I revise it, but not with the revision, but it actually is a conversion into the fusion, which is of course is not easy. You need bone graft, etc. But it's still is achievable. So I think I'm not too worried about complication. I can still manage complication, but may not. I don't have the revision implant experience, but I think revision to a fusion is still manageable. Thanks. So overall, my experience I think is still very pleasant. But because of the radiological the problem, I strongly suggest we should follow up every year at least to check radiologically. I don't call you up to correlate with the clinical function. Sometimes they actually happen to have a synovitis. When you see radiological lucency, they usually accompany some degree of synovial abrasion. They may not be painful. Those non-painful patients may just to continue to observe. But if you see the continuous sign for lucency, I think you may have to go in to do something before it really turns into the symptomatic. So that is so far my experience. Thank you.
Thank you, PC. Rich experience. Ollie, your hand's up.
Yeah, just a comment. I don't think I've been lucky doing this for many years. That's why I have operated many patients. I don't think you have to do. I'm not very. I'm probably not very clever, so you can be a very skilled arthroplasty surgeon with a much lower number than me. But there's one thing about surgeons. Some surgeons, they approach surgery as if it is a girlfriend you're going to conquer or a mountain you're going to conquer. And the minute you've done the procedure, you're kind of not interested in it anymore. And this is not a procedure where you should have that approach like it's something to brag about. It's more like operating your uncle or aunt or your cousin. You're going to the result is going to stick with you, and you have to accept it. The patients, they will come back and tell if they're satisfied, and they'll come back if they're not satisfied. And that's the way you should think about this procedure, at least for me. And in my experience, in most of the patients, the radiological appearance actually follows the clinical appearance. If they get distal loosening, you can immediately see it on the quick dash and the PRWHV. Although I don't have to revise them, but they get a worse clinical result, both in terms of pain and function. Then you can discuss with them what to do. I mean, I have patients who are loose, but they don't. They feel fine, and then of course I won't operate.
Ollie, then Dan, I'm going to ask you. You mentioned clinical, obviously important rather than radiological, perhaps. But do you have a fixed point in mind when you will see a patient back in the future years? Is there a time scale for clinical assessment for you?
Asking me?
Yeah.
Well, we have done follow-ups 1, 3, 5, and 10 years. I think if they work well after 1 year, we could skip the 3-year thing. But I think it's okay because there are problems you can solve for the patients that usually, I mean, they get carpal tunnel syndrome, tendinitis, they have CMC1 problems, and they think it's the wrist, and they can have problems with the wrist arthroplasty. So, and it's not that many patients, so I take the time to see them again. And I tell them that I'll see them until the end of time, or when they get sick and tired of me, so they can decide after 10 years.
Thanks, Ollie. Dan, what's your routine follow-up?
Yeah, I follow them up to a year myself. And then at a year, if they are well functioning and they're happy and they've got a good set of x-rays, they go on to our long-term surveillance pathway, which is run by a specialist nurse, and she contacts them at 2, 3, 5, 7, and 10 years. She goes through PRHWE with them, satisfaction and VAS score, and asks them obviously about complications. And then she arranges with them to get an x-ray. If they're local, they come back to us to have the x-ray. If they're not, they have it closer to home. And then she and I review the x-rays of the patients. And if there's any concerns, the patients are brought back to see me. We do that. I think it's important from an implant point of view. We don't want to get into the situation that other centres have got into with other wrist replacements, where they thought everything was doing well, and then all of a sudden they realised they were getting catastrophic failure at the 5-year mark, by which point they'd missed the boat in terms of being able to do something about it. So I want to know if a patient's having problems before they've got significant bone loss, before they've got a fracture, while I can still consider revising it for them and sorting it out.
Yeah, thank you. I'm going to come back to Ollie, actually. We've got 2 questions on the board. We'll answer both of them, or approach both of them. First, from Christian Mariathas, asking about the total wrist arthroplasty components, or proponents of. How do you feel about the clinical impact of the change in bearing surfaces to the MOTEC? Ollie?
Well, there have been 3 bearing surfaces: metal on metal, and metal on PEEK, and metal on ultra high molecular weight polyethylene. I've used them all. Now I only use the ordinary polyethylene surface, and haven't had any change in the result or problems with the polyethylene. Metal on metal came in, what do you say? It came in Wayne, or what is it? What you can say, at least in Norway. So although we didn't see very much problem, it was difficult to offer it to patients after the hip arthroplasty problems.
Dan, any thoughts on the components?
Yeah, I mean the worry with the metal on metal was obviously the hip thing, which is a totally different situation with a much bigger head, much bigger forces, and obviously there are certain metal on metal hip replacements that work brilliantly and still work brilliantly. So per se, there's nothing wrong with the bearing surfaces. It's a perception of the bearing surfaces that's a problem, and there are certain parts of the world and there are certain patients who just don't want to consider metal on metal. PEEK was a good option because it's very hard wearing. It wears better than polyethylene, but there's been some bad experiences with PEEK in other joints, and also it's not particularly well proven. So again, there were certain markets, certain places where it wasn't a good idea. And so everybody was saying, why don't you just use polyethylene, because that's the accepted bearing surface when in other joints. I still use metal on metal. I've got very good results with metal on metal. I've not had any problems with metal on metal. We've done the explant analysis, which shows that they're not seeing the same problems that you got in the hip. I've got patients who've had metal and metal implants in for 10 years or more. And it, it's an extremely hard wearing bearing. We've got the best part of 10 years experience with the PEEK. We haven't got long-term outcome with the polyethylene, but it's good polyethylene that's been used in other joints. It's vitamin E impregnated. It's sterilized in inert gases. So there's no reason why you'd expect there to be a problem with the polyethylene. I think if the poly had been available from the beginning, they'd probably have just made it as a metal on poly implant, because that's the same as everywhere else. But the issue was making a thin polyethylene strong enough at first. So I would tend to go with the poly or the metal.
Thanks, Dan. Final question to first Ollie, then Dan, and then I'll hand over to Rebecca. So Greg Bain asks, typically when inserting the Motec, it will not reproduce the normal center of rotation of the wrist. Do you modify how you insert the prosthesis to in part correct the center of rotation? Ollie?
That's not my first concern. I mean, this is a compromise, a dual level joint, making it into a one level joint. So it can never be, you can never get a perfect center of rotation if you don't do an real anatomic dual level arthroplasty. I focus on not getting it overstuffed and releasing enough so that I have enough space for maximum range of motion on the table, because that, in my experience, the main problem has been implanting the arthroplasty and ending up with not complete range of motion on the table. That is the circumduction that Danny talks about, and getting the wrist all the way so that the neck impinges on the socket. So and then you have to compromise, and usually I end up with a more proximal center of rotation as compared to a normal wrist. But then on the other side, these are not normal wrists, so the soft tissue is adapted to another situation than what they had when they were 17. So, yeah.
Thanks, Ollie. Dan, final comment?
Yeah, I sort of agree with everything Ole just said, really. The central rotation of the normal wrist is in the proximal end of the capitate, although it does vary depending what the wrist is doing, which movement it's making. The ideal central rotation of a Motec wrist is probably halfway between that and the articular surface. It's about 7 to 8 millimeters distal to the articular surface. And if you do move more distally, so you're moving the Motec towards the original center rotation, you change all the moment arms and you get that impingement that Ole was just talking about earlier. And you actually can get a whole different set of problems. So when the central rotation is too distal, you get significantly more impingement, and you significantly decrease range of movement and significantly more force needed to generate that movement. And I didn't preempt Greg to ask the question, but thank you very much for asking the question, because the paper that explains all this has literally just been accepted by the European Journal and should be online within a week or two.
Thanks, Dan. Thanks, Holly.
Okay, all right, folks, we've had a most interactive discussion on this perennial topic on the degenerative risk. So we've all come here with open minds to revisit this very common condition we manage day in and out, and it's certainly been interesting to gather experts from all over the world to share their experience, and I'm sure every one of us here have learned new things that we can hopefully apply to our clinical practice. So once again, it's good morning, afternoon, and night to all you lovely people out there, and please have a restful remainder of the weekend. Okay, thank you, everybody. Thank you. Goodbye, and see you again soon.
Thank you. Bye-bye.